Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. So today I will give a lecture uh, with the topic principle of anesthesia and pain relief. So this is just a brief lecture, the overview regarding the anesthesia and pain relief, because the detail of the topic we will discuss again during your year 4 posting in anesthesiology posting. Okay, before we going further, I just show the history of anesthesia. It is actually it's starting a long time ago when during the 12th century, Ibn al-Kuf described in his book Al-Umdah fi Sinat al-Jirahah regarding the sleep and insensibility inducing substance were contributed by opium, which is nowadays we use the opioid, and belladonna, mandrake, cannabis, and also violators. And later on, the Europeans practiced the same concept but slightly with different ingredients. And during the modern history, 17th century, Humphrey Davy discovered the laughing gas, which is we known now as nitrous oxide. And during the 1846, the William Thomas Green Moulton, he described the first ether anesthesia, and this is what basically why on 16th October we celebrate as World Anesthesia Day, because to remember the memories of the Moulton used the first ether anesthesia at the Boston, at the Harvard Boston during that time. Okay, this is just the short brief history regarding the anesthesia history. And what the I think I'm not sure whether you all still remember or not. The Meg Ryan, she described that the best thing about the modern living is anesthesia. Okay, I just give the term. The anesthesiology is basically the practice of a medicine providing insensibility to pain during surgical, therapeutic, and diagnostic procedure, which I get the definition from the ASA, American Board of Anesthesiology. And also the analgesia is a process of relieving or reducing pain, and the analgesic is the drugs that provide the pain relief. And the person we call anesthesiologist is a highly skilled medical expert in anesthesia care, pain management, and also a critical care medicine. So for the technique of anesthesia, we can divide into general anesthesia, regional anesthesia, monitored anesthesia care, and also local anesthesia. So for the general anesthesia, we also can further divide into the balanced anesthesia and also total intravenous anesthesia. For the regional anesthesia, we use the neurosal block, which is a spinal or epidural or combined spinal epidural. We also use plexus nerve, peripheral nerve block, and also intravenous regional anesthesia, which is really we use nowadays. And also we have the monitored anesthesia, and also for the local anesthesia, which is topical or infiltration. First, we go to the general anesthesia. So for the general anesthesia, we use the drug-induced loss of consciousness during which patients are not arousable even by painful stimulation. And for the general anesthesia, the medicine that we give to the patient can administered via a mask, which is inhalational, or we use by IV intravenous. And the concept of a balanced anesthesia, which we use the triad of amnesia, unconsciousness, and also analgesia. So the concept of using combination of drugs and technique such as pre-medication, general anesthesia, and regional anesthesia to provide the triad anesthesia, which I mentioned just now, analgesia, anesthesia, and also paralysis. And each drug reduce the requirement for others, thereby reducing the side effect due to single agent, thereby increasing the safety profile and allows faster recovery. For the total intravenous anesthesia, it is the usage of combination of anesthetic agents given solely by intravenous route, which mean there are no volatile agent, including nitrous oxide, and the drugs are given by infusion to achieve hypnosis, analgesia, and sometimes paralysis. So for the joint anesthesia, we can use either combination of the gas, volatile, which is volatile agent, and also intravenous. And also we can use slowly by intravenous, which is total intravenous anesthesia. Okay, this is the two picture. At the left side, the anesthesiologist intubate the patient using the laryngoscope and endotracheal tube. And on another side, the anesthesiologist try to insert the laryngeal mask airway. So the both procedure is we use the both procedure we use during the general anesthesia. So for the general anesthesia, a variety of drugs are given to the patient that have different effects with the overall aim of ensuring unconsciousness, amnesia, and analgesia. So because I know now you are in a surgical posting, so when you went to the OT, you more concentrate for the surgical procedure, but you can notice at the head of the patient, there are one person uh, doing the charting, take care for monitoring, and any alarm come from the GA machine. So uh, that is anesthesiologist. So basically, the anesthesiologist they control all when surgeon doing the operation, the anesthesiologist will care more the mean the try to see the physiological and pharmacological part going on to the patient. So the anesthetist will records the vital signs and drug already used, and also the anesthesiologist also will monitor the blood pressure, the patient heart rate, the oxygen saturation, oxygen levels in the blood, and also will control the flow and concentration of gas mixture, and also regulated the machine by setting, because when we give the anesthetic drug, of course, patient will loss of consciousness. So when a patient loss of consciousness, the respiratory drive also reduce. So that's why we need to have to ventilate the patient. And let's say if we give the paralytic agent, means a patient no breathing by his own. So that's why we need to use the ventilator to help to assist patient breath. And because as you know, our induction drug can cause, our anesthetic induction drug can cause uh, cardiorespiratory depression. So that's why we need to monitor for the heart. Of course, we need to monitor the blood pressure, heart rate, and also uh, for the ventilation, we need for the ventilation, and we need to monitor the end-tidal of carbon dioxide, and also the oxygen level. We need to monitor the SpO2. And once the surgery is complete, so the patient will be reversed. And some of the patient feel fine as they wake up, but some of others might experience symptoms such as nausea, vomiting, or chills, and also because due to either due to the anesthetic drug effect, or maybe due to some procedural effect. And the throat may be sore due to endotracheal tube. So that basically what's going on during the general anesthesia procedure. And this process, you will learn again during the anesthesia posting, because for the general anesthesia, we have the stage and the process from the induction, maintenance, and also lastly when during after the operation finish, we will reverse the patient during the recovery or during the emergency. Next, we go to the regional anesthesia. For the regional anesthesia, it is anesthesia of only specific part of the body, such as limb or lower half of the body with the consciousness remaining intact. So you can see from here the advantage of regional anesthesia compared to general anesthesia. So for the regional anesthesia, because you only give the local people here, they call the regional anesthesia as bius separuh, or for the general anesthesia, bius penuh. So you can see here the advantage is because the consciousness remaining intact, so you can patient remain conscious and patient can breathing by his own. So you can avoid the complication of general anesthesia, such as the complication of intubation and also the complication from the certain drugs. And for the regional anesthesia, you can deliver by neurosynaptic blockade or central neurosynaptic blockade, which mean the local anesthetic administered into either the spinal or epidural or both, combined spinal epidural. And also the regional anesthesia can be achieved by the plexus or peripheral nerve block, which means the local anesthetic is injected in close proximity to a plexus or specific nerve to block the sensory transmission to the spinal cord or central nervous system. And this is how the spinal anesthesia is going on. So at the left picture, it is the procedure. The anesthesiologist insert the spinal needle, and when the anesthesiologist confirm there is intrathecal or subaortic space. Subaortic space you confirm by you can see the clear cerebrospinal fluid flow. Because the different I think you also learn in medicine or pediatric regarding the lumbar puncture. So basically the procedure to insert the needle for the spinal anesthesia is same such as the lumbar puncture. I mean the structure is same when you pierce the needle from the skin, subcutaneous tissue, all until the subaortic space is same, except for the lumbar puncture is for the diagnostic purpose. Mean you take out the cerebrospinal fluid to send for investigation, but for the spinal anesthesia is for the therapeutic, or you want to administer the drug. Means after you see the clear CSF, so you administer the drug. So this is the picture. The other picture show when you have the correct needle placement. Okay, when you have the correct needle placement at the subaortic space. So this one, when you administer the local anesthetic agent, so local anesthetic agent will spread through the subaortic space. And all regarding the technique and the medication we use, we will I will further you will learn further elaboration during your anesthesiology posting later on. And this is for the epidural anesthesia. So for the epidural anesthesia, just now I showed the picture for the spinal anesthesia. So for the spinal anesthesia, just insert the spinal needle and you give the local anesthetic through the spinal needle. But for the epidural anesthesia, you also put the patient in same position like the spinal anesthesia, but the difference is for the spinal anesthesia, you insert the needle until the subaortic space, but for the epidural, you insert the needle until the epidural. You insert the needle at the epidural space. So For the spinal, you only insert the needle and give the drug. But for the epidural, you will insert the epidural catheter, and you will give the drug through the epidural catheter. That and that I mean the different of equipment and also the location. But another thing, when you give the drug, of course, the different is for the spinal anesthesia. It is the onset is fast onset, but for the epidural anesthesia, the onset is slower compared to spinal. So you need to wait for a while for the drug to take the action. Then you can allow surgeon to do the operation. So that's why in certain cases you can combine with spinal and epidural. And also another technique of a regional block we can achieve by giving the peripheral nerve block. So for the peripheral nerve block, you just block at the targeted or specific nerve. For this one, so for the peripheral nerve block, for the nerve block, you need to remember back what you learned during your central nervous system module or musculoskeletal module. Like this one at the uh, neck or shoulder. So during this time, you can recall back regarding what you learned regarding the brachial plexus. For the brachial plexus, from the uh, root, trunk, division, until the cord and branch. So like for the interscalene, uh, supraclavicular, infraclavicular, and axillary nerve block. So this one you need to recall back what you learned during your musculoskeletal module or during your central nervous system module. But for today lecture, I just give the view. What I'm not elaborate the detail, but to make you clear, for the regional nerve block, you have the option. Either you want to give the central venous blockade, which is spinal or epidural or combined spinal epidural, and also you have the other option, which is peripheral nerve block. So you target at the specific nerve block. For the lower limb, for the upper limb, yes, you can target the brachial plexus. But for the lower limb, maybe you can target the femoral nerve, further down the popliteal nerve, and also go further down, you can target at the ankle block. So that all we will discuss again during your anesthesiology posting in year 4. And next, after you know regarding the general anesthesia and regional anesthesia, now we go to the next technique, which is monitored anesthesia care. So for the monitored anesthesia care, it is a specific anesthesia service involve varying levels of sedation, analgesia, and anxiolysis as necessary. So the anesthetic agent used for the monitored anesthesia care, which is for the sedation, we have the option. You can use propofol or Presidat, dexmedetomidine, or we also can use the analgesia, which is the remifentanil, ketamine, and for the anxiolysis, we can use midazolam. And when we administered the monitored anesthesia care, the standard of care, same as like you provide the general anesthesia or regional anesthesia. Means the standard of care like the monitoring. So the monitoring same. We follow the standard American Society of Anesthesiologists, the standard ESA monitoring. Mean we need to monitor the blood pressure, heart rate, saturation of the oxygen, carbon dioxide, and also we need monitor the patient as usual, same as you give the GA or RA. And for the monitor anesthesia care, commonly it apply in diagnostic or therapeutic procedure. For example, for the awake fiber optic intubation, for endoscopic procedures, and etc. And Next, the the other technique that we can provide is local anesthesia. So I think this one is you commonly or the surgeon commonly administered. The surgeon commonly administered the local anesthesia. So the local anesthesia we either can provide via topical anesthesia and also infiltration anesthesia. So usually the surgeon will give the uh, local anesthesia through the infiltration anesthesia. So the infiltration anesthesia you can give uh, via subcutaneous and intradermal infiltration of LA agent around the lesion either before or after the surgery, minor procedure, or during the suturing. And for the topical anesthesia, it involves the application of local anesthetic agent to either skin or mucous membranes such as conjunctiva, nasal passage, larynx, pharynx, rectum, or urethra to produce anesthesia. It also can deliver via spray, paste, ointments, swab, or direct installation. And the commonly local anesthetic agent used is lignocaine, cocaine, and also amla cream. Use that AMLA is abbreviation for eutectic mixture of local anesthetic. So for the local anesthesia, you can use either the topical anesthesia and also by skin infiltration anesthesia. And next we go to the other the other part of our topic today, pain relief. So just now, you can see the overview of regarding the anesthesia. So for the anesthesia, you can see here. So basically, how you provide the anesthesia to the patient. I just recap back what I gave the lecture just now. For the anesthesia, you can give either general anesthesia, regional anesthesia, monitored anesthesia care, and also local anesthesia. So commonly when you go to the OT, when you see patient unconscious, so that means a patient receive general anesthesia. But let's say if for the certain procedure, when you see patient remain conscious level, but uh, the certain part patient cannot move their limb, which means patient receive either let's say patient cannot move both limb, means patient already received the central nervous blockade, but sometimes if a patient only specific part just do anesthetize, specific part patient just don't have a sensation and also cannot don't have power, so means you provide the peripheral nerve block. And for the other thing for the local anesthesia, usually for the local anesthesia, you usually seen what the surgeon doing the some short procedure in the clinic just by giving the local infiltration. And also local anesthesia, you also can see in the OT at the end of operation, the surgeon will infiltrate local anesthesia at the specific part. So this is the overview, what the techniques of anesthesia we provide during the procedure, either general anesthesia, regional anesthesia, monitor anesthesia care, and local anesthesia. And the further detail regarding this part, we will learn again during your year 4 anesthesiology posting. Okay, next we go to other part, which is pain relief. So first, for the pain, this is the standard definition of the pain, which we take from the IASP, International Association, the International Association for the Study of Pain. So they give the new definition last year. They revised from the prior definition. So the pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Okay, that the definition of pain that adapted from the IASP. So the presence of a body injury causes the nerve endings to transmit pain signals along the nerve into the spinal cord and eventually to the brain. So of course, the managing pain is a very important, and our KKM, the Ministry of Health, already launched the pain as fifth vital sign, and also they promote the concept of pain-free hospital. And the post-operative pain is crucial, as you know, the pain can physiologically induce the release of stress hormone such as cortisol and catecholamines, hypercoagulability, and also inflammatory mediators, for example, cytokines, bradykinin. And when we provide the pain relief, when we alleviate the post-operative pain, it promote the advantage. We can promote the faster recovery and also reduce the chance of the pain becoming chronic pain. And this is our local guidelines for the pain management from our Ministry of Health, and also some of the guidelines that we can take from the Malaysian Association for the Study of Pain. Okay, now we go to the how we classify pain. So we can pain we can classify based on duration, causes, and also mechanism. So for the duration, we can divide into the acute and chronic, and also acute and chronic. But basically, the difference between the acute and chronic, the duration, anything beyond or persist more than 12 weeks or 3 months, we consider as chronic pain, and less than 3 months, we consider as acute pain. And for the causes, we can divide into the causes of the pain, either cancer or non-cancerous. And for the mechanism, we can divide into the nociceptive and also neuropathic pain. And also nowadays we have nociplastic pain. So the causes of acute pain, maybe the pain can occur after the surgery, or maybe the pain can induce from the injuries or trauma or burns, and also the pain from the disease, for example, angina pain, or from the joint pain, arthritis, or maybe due to cancer or stones, and also when you attach to the ONG posting, you will deal with the labor pain. And for the mechanism, as I described, as I mentioned before, nociceptive and neuropathic pain. So for the nociceptive pain, it is the obvious tissue injury or illness, and it also called as physiological pain. And pain has a protective function, for example, to prevent further tissue damage. And for the nociceptive pain, when you take the history, it can describe as the sharp and dull. It can give patient can describe as the sharp or maybe dull, and also, but for the nociceptive, it is well localized. And for the neuropathic pain, as the name neuropathic, so it come from the nervous system damage or nervous system abnormality, and it also called as pathological pain. And compared to nociceptive pain, neuropathic pain, the tissue injury may not be obvious, and it does not have a protective function. And usually the patient will describe as a burning, shooting and numbness, or pins and needle sensation, and it is not well localized. For example, for the neuropathic pain, maybe patient with long-standing history of diabetes, so might complicated with diabetic neuropathy. So patient will come to you and describe as pins and needle sensation. And also another example, like patient with varicella zoster or shingles. So patient will shingles, patient will describe have a burning or shooting pain. And another example of neuropathic pain like trigeminal neuralgia. Trigeminal neuralgia, so patient will come to you described as a lancinating pain. So that during the history taking, you can differentiate whether it's neuropathic pain or nociceptive pain. For example, now you in surgical posting, patient come to you with, for example, acute appendicitis. So for the acute appendicitis, maybe patient can, how the patient describe to you, is it the dull or is it the sharp or where the location are. So that you can differentiate whether it is nociceptive or neuropathic pain. And you need to remember the nociception is not the same as a pain, because nociception is how signals get from the site of injury to the brain, while pain perception is how we feel pain. So nociception is not the same as a pain. And this is, I think you already familiar with this diagram. I think you already learned during your physiological, during your preclinical years, how the pain transmission or pain signals when from the trauma tissue injury. So the pain signals via the transduction, transmission, modulation, and also at the center, at the brain, give the perception of pain. Why this diagram important? Because when you understand this physiological pathway of the pain, so you know how to target and treat the pain. And also, I'm sure during your learn this pain signals, you also learn regarding the nerve transmission. For the transmission, they have either C fibers, A fibers. For the A fibers, also have A delta, A beta, A alpha. So that's all you learn during your preclinical years. And this one, I adapt this basic framework to manage the pain from the essential pain management. It is from the College of Pain from the Australia and New Zealand. Initially, they developed this essential pain management module. So I just adapt this module for our lecture today. But I just give the short from their just summarize from their module. So this is I put the rat, the picture of the rat, because rat means how to manage the pain. First you need to recognize the patient pain, and then you need to assess the pain, and then you can treat the pain. So first, for the recognize, how you recognize a patient having pain or not? So by you can ask the patient, and also you can from your observation, you look at the patient, whether you can look at their features like frowning, moving easily, sweating, or any pain behaviors. Or let's say if a patient is unable to communicate, or patient with dementia, maybe the pain history difficult for you to get the history. So you can either you can look at the patient behavior, or maybe you can ask the patient surrounding themselves. And so you can ask other people whether they know that patient has pain or not. And and also you can get the history from the other health workers, and also from the patient's family. Let's say the patient already admitted to the ward, maybe you can ask the health workers there regarding the behavior of the patient at the ward, or maybe you can take the history from the patient family. And after you recognize the patient have the pain, so next you need to assess the pain. So it is important always try and work out what the underlying cause of the pain is, and treat this cause. Because as you know, the pain came from many sources. So important, you need to know what the underlying causes so that you can treat these causes. Not only you treat the symptom of pain, but you treat the causes, what give rise to the pain. So the few pain assessment tools that we can use, such as simple descriptive scale, numeric rating scale, visual analog scale, one Baker face pain rating scale, and also FLACC scale. So this pain assessment either unidimensional and also multidimensional. So this is the pain ruler from our Ministry of Health. So this is the combined visual analog scale and numeric rating scale, and it is suitable for the adult and children more than 10 years. Where mean during the pain service round, you can when you assess the patient, you can give this ruler to the patient, and you can explain to the patient where the patient feel pain when you give the scale, when is patient want to put at this ruler, whether zero means patient don't have pain, so patient can put zero, or maybe pain just patient cannot bear, cannot tolerable with the pain, and maybe until up to the 10. So you can give this scale to the patient. And let's say for the pediatric patient that not understand the ruler, maybe you can give this one Baker face pain rating scale. So you can ask the child to put at which phases this patient. Let's say if patient happy, no pain, maybe it will put at this phase. Maybe so means at this phase 0. At this phase, maybe you can put at 1, 2, or 3. Let's say this phase, okay, you can put as 10. And another thing, for the adult, of course, you can use the ruler for the visual analog scale. And for just now, you can use also one Baker face. And also you can assess the pain by FLACC pain scale. Means F face, L legs, A activity, C cry, and C consolability. So you can score the pain by assess the behavior for the patient. Because this one maybe from the pediatric patient that from the non-verbal patient, maybe for non-verbal patient, you very hard to get the patient to show at the ruler, so you can assess by their behavior. So you already know how to recognize the pain, and also you know how to assess the pain. Next, we go to the treatment. As we stress again, treat the underlying cause is if possible. And you need to assess and classify pain correctly, then think of treatment and management of the pain. And also for the management of the pain, non-drug and drug treatments are equally as important. And for the non-drug treatments, we can consider for all types of pain, and the drug treatment can give both for the nociceptive and neuropathic pain. And remember to, after we give the treatment, remember to reassess the patient whether the treatment is working or not, or whether we need other treatments to add on. And also, of course, after you give treatment, you need to monitor the side effect and complication of the treatment. Here we back again to this pain pathway. So that's why I said this pain pathway is important, because okay, from at the transmission, okay, just now from the transduction, transmission, modulation, and perception. Okay, for the transduction, you can the agent you can give, such as the opioid, local anesthetic agent, anti-inflammatory agent. You can give to alleviate the pain. And also for the transmission, you can give local anesthesia. For the modulation, you can target at the dorsal root ganglion. And the drug of choice, you can give local anesthetic, opioids, and also COX-2 specific inhibitor. And for the perception at the brain center, you can give opioids, alpha-2 agonist, centrally acting analgesia, and also anti-inflammatory agent. So you can target at which level you want to treat the pain. And for the option of analgesia, either you can give pharmacological, non-pharmacological, and also complementary medicine. For the pharmacological method, for example, opioid, non-opioids, local anesthetic, and also adjuvant drugs. And all the drug I give, this is just example. Actually, we have a lot of option of drugs. And the route of administration, either you can give via oral, rectal, intramuscular, subcutaneous, or intravenous injection. I think you already learned during your pharmacological, during your preclinical years, the route of administration. First, this one I just give the example of the common medication that we use, and also just a brief description and explanation. I say for the first one, acetaminophen, also known as paracetamol or Panadol. It is treat the mild to moderate pain, and the action central inhibitor of prostaglandin synthesis, and it also can use as the adjunct that can combine with other pain medication. For example, you can combine acetaminophen, paracetamol with opioids and NSAIDs to relieve more severe pain. And for the acetaminophen, it also have the risk of it also have the side effect, but the risk of side effect is low. And it also can be used to who cannot take the drugs like aspirin. For example, patient with asthma or stomach ulcer that this patient cannot tolerate with the aspirin, so you can use acetaminophen or paracetamol. But you need to use cautious with a patient with a liver disease, because you know the metabolism of these drugs at the liver. And next, the other option is anti-inflammatory drugs. It include NSAIDs, non-steroidal anti-inflammatory drugs, and also the selective cyclooxygenase COX-2 inhibitor, for example, mefenamic acid, ibuprofen, and also diclofenac. And the examples of selective cyclooxygenase 2 inhibitor, such as parecoxib or denostat, atriocoxib, pacoxia, and also celecoxib or Celebrex. The name, I think you also know regarding the generic and also the trade name. Okay. We also use the NSAIDs to treat mild to moderate pain. And the COX-2 inhibitors is equally effective as NSAIDs in terms of pain control, and they cause less gastric and bleeding problems. However, the effects on the renal is similar. So I think the cyclooxygenase pathway, the prostaglandin pathway, I think you all in surgery posting, maybe you already well remember and understand regarding the prostaglandin pathway, because so that's why you know when you give NSAIDs, it can give a risk more to fatty ulcer disease. So you need to avoid NSAID in post-operative patients who have ongoing bleeding, hypovolemia, and also pre-renal uremia. For the NSAIDs, I not give the elaboration regarding all the pathway, but I think you already familiar regarding the pathway. And next drug is opioids. So the opioids, it acts on the mu opioid receptor in a central nervous system, and we use opioids to treat moderate to severe pain after surgery or injury. And examples of the opioid, morphine, which is the gold standard of opioid is morphine. And also we can use other opioids such as fentanyl, pethidine, and tramadol. And the advantages of opioids, it do not cause stomach ulcers or bleeding. And you can combine with the paracetamol and NSAIDs as adjuvant with the opioid. And so the advantage when you use a different type of the drug, so you can reduce the dose of opioid needed. And however, the disadvantages of the opioids, patient might experience nausea, vomiting, excessive sedation, pruritus, constipation, and also, of course, you worry regarding respiratory depression. So when you give the opioid, particularly through the intravenous, so you need to watch out this side effect. And another option is local anesthetic agent. So local anesthetic, it act on the sodium channel blocker, which inhibit the action potential and subsequently blocks the nerve that pass pain signals to the brain. And it for the local anesthetic agent, it's effective for severe pain, and you can use the local anesthetic agent for it can be given as wound infiltration, peripheral nerve block, and also central nervous blockade. I mean, the technique of anesthesia before, which I described, the central nervous blockade, peripheral nerve block. So the drug that you use is local anesthetic agent. So for the but of course during this short lecture, I not further elaborate you all the type of local anesthetic, because a local anesthetic it can further divide into two type, either ester or amides. The later on you will learn further regarding this drug during your anesthesiology posting. But at least you know the local anesthetic agent you can use for the when you give spinal, epidural, and also for the wound infiltration. And the advantages of the local anesthetic agent, it minimize the risk of sedation, nausea, vomiting, or respiratory problems, because you know the mechanism, it act on sodium channel blocker. So means the drug at the sodium channel blocker which inhibit the action potential. So that's and subsequently it block the nerve that pass the pain. So that's why it not involve your you're not involve your respiratory center unless you give the higher dose. Unless you give a higher dose, the patient complicated with local anesthetic toxicity, or maybe high when you give spinal, patient complicated with total spinal or high spinal, then it can cause a patient cardiorespiratory collapse. But if you give with proper technique and a correct dose, so the advantage you can minimal the risk of respiratory problems. And also you can reduce the need for other analgesic agent. However, disadvantages of local anesthetic agent, of course, the longer preparation time. For example, when you plan to do the central nervous blockade or peripheral nerve block, so you need take time to prepare it, and also prolong recovery time, because when you learn detail regarding this drug, the duration of the drug, so that's why prolonged recovery time. And also it can complicated with certain complication such as post-dural puncture headache in central nervous blockade. That among the disadvantages of the local anesthetic agent. And this is I give the summarize some the important medication that we use in the pain management. So you can see this table later on, but the common medication that we use in pain management. Okay, this is I give the example, the techniques of anesthesia that we use in the ward. So this one, I show the picture of patient control analgesia, PCA. You can see for the PCA, this is the PCA pump. And for the PCA pump, you see we that pump is empty, don't have the syringe. But for the PCA pump, we put the syringe here, the syringe that contain the medication. For example, the opioids, whether fentanyl or morphine. So you can put in this PCA pump. And when you give the PCA patient control anesthesia, because the name also patient control, so when you give this technique, you ask the patient him patient he or herself need to press the button, press this button. So this is the safety feature of this technique. Mean the medication is controlled. The patient receive the medication is controlled by themselves. Means let's say if a patient don't feel pain, they no need to press this button. And let's say when a patient press this button frequently, or maybe the drug make the patient feel sedated, so maybe patient will feel sleepy, so they don't press anymore this one. So for the patient control anesthesia, you need to instruct the patient she or himself only can press this button, not their caretakers. And the other techniques of analgesia, just now, earlier part, I mentioned regarding epidural analgesia is the option for anesthetic technique. But for the epidural, because epidural, you insert the epidural catheter, so post operatively, although patient from the OT, you bring patient to the ward, you still can keep the epidural catheter for certain days, like for 2 days. So from this catheter, you still can infuse the drug. So basically, you infuse the local anesthetic agent, local anesthetic mixed with the opioid. You can give via this epidural catheter. And that's all for, for today's lecture. And because this now you in the surgical posting, so I just give you just the brief and short lecture regarding the principle of anesthesia and also principle of pain relief, and all the detail regarding these techniques. We will meet again during next year during your year 4 during anesthesiology posting. And I think that's all for this lecture.